Welcome back, everybody. We're on the home stretch now of our Research Forum Day, and it's lovely. I hope everyone's had a chance for a bit of a stretch and a cup of tea and ready for the last two presentations of our day. I'm very delighted to introduce Dr. Aghareed Al-Kassab. Aghareed is a research fellow at Spectrum, and she completed her PhD at Melbourne University and has had quite an illustrious career publishing and training since then. And she joined Spectrum about a year and a half ago, and we've been delighted to have her as part of our research team. And one of her integral roles has been making some sense of all of our evaluation data, which is looking at our treatment programs. And it's very exciting today. She's going to be presenting that work to us. And I think it's really critical that services evaluate themselves and see how the treatments are affecting our clients and whether we're having the positive effects that we think we are. So we learn a lot from these, and Aghareed is here to teach us. So thanks very much, Aghareed.
Thank you, Gillian. Thanks for introducing me. Good afternoon, everybody, or good morning, maybe. Good afternoon from the Southern Hemisphere. Today, I'm going to present findings from our Spectrum Service Evaluation Program. So I'll just share the slides. So some of the slides may overlap the slides that Sathya presented. However, I'm just going to a little bit expand on the material that Sathya presented and mainly focus on the outcome from the Spectrum Evaluation Service Evaluation Program. The Service Evaluation Program was established by Spectrum to introduce the effectiveness of the specialist psychotherapeutic treatments provided by Spectrum. The program was implemented to be carried out as part of the routine care of all clients admitted to Spectrum for treatment at the different psychotherapy clinics. The program was also designed to deliver detailed diagnostic information to clinicians to enable them to provide individual client feedback and inform treatment direction and clinical reviews. And as you know, that people referred to Spectrum for treatment have severe mental health difficulties that often public mental health services are struggle to manage. Therefore, the objective of this presentation is to report on the effectiveness of the evaluation program in detecting a clinical change across a range of endpoints relevant to remission and recovery from BPD. Among the endpoints reported are symptom change over time, self-injury, suicidality, low mood, and quality of life. The evaluation program consists of a set of measures of which their frequency of administration was during the initial assessment, once treatment commences at 6 monthly intervals, and until discharge, which was set at 18 months. So basically, the evaluation was undertaken across or over 4 time periods. That's at baseline, 6 months, 12 months, and then at discharge, which was set at 18 months. The selection of the evaluation measures was made based on updates on personality disorder and in light of the available literature where similar validated and core measures have been used in order to make the outcomes from the evaluation program comparable with the international studies across the different domains. So there are 3 interview style questionnaires administered by clinicians and 6 self-report measures or otherwise known as client-administered measures. So the clinician administered questionnaires or instruments included the SCID to assess personality disorders, also including ASSIST that assess the harmful substance use, and also SASH, which was developed by a SASH questionnaire that assessed non-suicidal self-harm and suicidal ideation and behavior. And this questionnaire was developed by Spectrum. In addition to assessing symptom severity, the self-report measures also assess several areas where difficulty is commonly experienced by individuals with borderline personality disorder, including in emotions, mood, social and functional activities, behavior and relationships with the self and with others, and also eating habits. In terms of scoring and administration of the questionnaires, for the clinician-administered interviews, they were conducted either like in person or like virtually. And of course, they were moderated by the clinician. And for the client-administered measures, they were also conducted either like in the clinic in person as pen and paper, or online using a web-based application known as REDCap. And also for the clinician-administered instruments, they were conducted twice, once at baseline at the intake and another time at discharge. Whereas for the client-reported measures, they were completed at 4 time points, that is baseline, 6 months, 12 months, and at discharge, as I mentioned. So our findings are 284 clients completed a treatment episode in a BPD-specific psychotherapy clinic provided by a BPD treatment specialist. Of those, 114 clients completed the full set of measures at all the 4 stages of the evaluation program. This, as I mentioned, at the intake, 6 months, 12 months, and 18 months. The majority of the participants were females with mean age of 33 years. And in order to make sure that our generated results are be considered representative for all clients seen or treated at Spectrum, we compared between participants who actually just initially engaged and they discontinued just soon after their engagement without a proper or like a planned clinical discharge, and they were 33 in number. So we compared their socio-demographic profile as well as their clinical measures that were taken at baseline or at the intake phase with the same number with those who completed the full evaluation program as well as the full course of a treatment, and both the groups were matched by age and gender. So our results found no statistical difference to be reported in terms of the socio-demographic profile as well as in terms of the outcome measures completed at the intake between the completers and non-completers, except in the use of harmful substance use, where tobacco, cannabis, and the amphetamine were significantly more consumed by non-completers compared to completers at the intake. So this was the only significant difference was found between completers and non-completers at the baseline phase. Now, discussing outcome measures for those 114 clients who completed the full treatment course as well as the evaluation program. In the next slide, I will be discussing outcome for clinician-administered measures. And then after that will be for the self-administered measures. So using the SCID, the number and severity for all subtypes of personality disorders, including for the borderline, were significantly reduced at discharge compared to at the intake phase. And specifically of note, that was for the depression and the borderline. and even like we see for other like personality disorders like at discharge, the line here looks like almost like flat. Here the percentage of self-harm and suicide attempt assessed during the last 4 weeks as well as the last 12 months at the intake as well as at discharge are shown so in these two figures. So repeated measures analysis reported that the percentage of both self-harm and suicide attempt at discharge for both periods significantly reduced at discharge compared to that when measured at the baseline. Harmful substance use was assessed using the ASSIST. Polydrug use was reported in about 71% of the clients, with the most frequently misused substances at the intake were alcohol, tobacco, followed by cannabis, while the consumption of alcohol and other harmful substances were significantly reduced at discharge. There was a little change or no significant change in the consumption of alcohol and cannabis at discharge. Okay, so now reporting on the outcomes for the self-report measures for, again, clients who completed the treatment course and the evaluation program. Depressed mood assessed by the Beck Depression Inventory Questionnaire steadily declined across the four below what is known as clinical depression. Of note, during the first 12 months of the evaluation, about 73% of a client, their BDI scores was reported to be at or above the threshold of clinical depression. So this was at the first 12 months of the evaluation. Then this remarkably dropped to 26% by 18 months. Disordered eating was a common co-occurring condition. At the initial assessment, clients reported difficulties with restraint, avoidance of eating, and daily concern regarding their shape and weight. This pattern continued throughout the evaluation, even exceeding the mean score noted for the general population. However, by 18 months, disordered eating scores for all the subscales substantially reduced. With respect to emotion regulations assessed with by the DIRS, there was a substantial improvement in the overall score at discharge compared to that at baseline. BPD symptom severity assessed with the use of BEST showed a significant reduction in its aggregate score at discharge compared to that the baseline. Same significant improvement at discharge was also reported in scores of the social adjustment scale, which was used to assess adjustment in social roles, interpersonal relationships, and feelings of satisfaction. And also same improvements was also reported in the overall score for the personal well-being index. Also, we examined the association between BPD severity with self-harm and suicidal ideation during the past 12 months of the evaluation. At admission, best total score were higher in clients who reported self-harming as well as suicidal ideation compared to participants who did not have self-harming or suicidal ideation behavior. Similarly, participants who reported self-harm as well as suicidal attempt reported more problems with emotion regulation measured by the DIRS compared to those who did not. At discharge, the severity of depression was quite high in those who reported self-harming compared to those who did not. This relationship was also evident for self-rated social and functional outcomes assessed by the short version of the SAS, which at discharge were significantly better for participants who did not report experiencing suicidal ideation. So in conclusions, it would appear from these results that engaging in self-harming behaviors and suicidal ideation are suggestive of greater severity of a client presentation, and continued self-harming and suicidal ideation may be associated with a less robust treatment response. And unlike other public mental health services, Spectrum is specialized in treating people with severe mental health difficulties. So the present findings robustly support the efficacy of BPD appropriate psychotherapy provided by Spectrum for promoting clinically significant improvements in psychiatric symptoms in people with severe and complex personality disorders. Last but not least, our project team would like to thank our clinical director, Prof. Safia, our head of research and innovation, Prof. Gillian, our clinical managers, and Spectrum clinicians and clients for their contributions to the success of the evaluation program. Thank you for your attention.
Thank you very much, Agareed, for your presentation. I just want to remind everybody that you can pop your questions in the chat. Agareed is here live and we will ask the questions of her. I have a question just right off the top of the bat, Agareed. You mentioned that it was BPD specific psychotherapy delivered by trained specialists. Can you tell me what kinds of psychotherapy, please, that we're talking about here?
Yeah, of course, Gillian. So Spectrum provided treatment in DBT, in MBT and ACT, and as also complex treatment, as also in PTSD as well.
Thank you.
Okay.
I think one of the really interesting findings from this is the perhaps use of self-harm and suicidal ideation in recent times as perhaps an indication of severity, because it certainly seems to show up on quite a few of the measures, doesn't it? Just wondered, in terms of treatment response, is this something that perhaps we're going to need to target? I noticed in Lois's presentation when she looked at all the different BPD specific treatments that MBT seems to have some success with self-harm and suicidality, and I have heard DBT does as well. So this clearly is a treatment target. Do you have any thoughts about that, just from your massive data exercise?
Yeah, of course. Yeah. Well, Gillian, yeah, as we all see that those like who are experiencing more like self-harm as well as suicidal ideation, they are at more risk. Or they reported like more severe symptom of BPD and other like psychological problems that I think clearly put them like, you know, a target group that they need to receive like first line treatment. And I actually, we have collected like more data about like methods of self-harm, like also like reasons for self-harm, whether they needed like admission to emergency department. And we have all this like, I haven't finalized like the results, and would be very interesting, you know, to find out more about more details about, you know, their self-harm and suicidal thoughts, behaviors, and link them to other self-reported measures as well.
It's fabulous. Agareed, I have a question for you. I also had a compliment. Someone said it was a great presentation. Thanks, Agareed, which is wonderful. We have a question. Was there any difference in outcomes for the different treatments offered at Spectrum?
Like in terms of yeah, between the different psychotherapy like clinics, no, there wasn't. Yeah, and the highest like because like MBT and DBT clinics, they were like the most like kind of clinics were dealing with the clients, and their clients were more engaging in the evaluation program compared to other clinics. Yeah, but yeah, there wasn't a difference like between 4 clinics.
Thanks very much, Agarit. Yes, that was something we were kind of curious about, whether there might be some differences, because the different modalities can focus on different aspects of BPD. The good news is, and with all the common factors literature that's coming through at the moment, it talks about how each of the treatments is effective and similar to each other. It tends to support that finding through our own work. I'll just check and see. I think there's no more questions that I can. Oh, yes, here we go. We do have another question for you. This is great. How do you choose assessment tools? I'm so curious.
Oh, yeah. So as I mentioned, like at the beginning of the presentation, the assessment tools were like selected. Not me, I didn't choose the assessment tools. It was selected like by panel of experts like psychiatrists and senior psychologists, like based on their clinical experience, as well as based on core measures being used like in the literature, because that was very important to make our outcome representative and comparable to the available international ones. So yeah, so that was the way how was the measures being selected. And I think all the measures like whether clinicians delivered measures or self-reported measures, they were they were all like I think extensively used by other studies. And this I think has its own advantage by making our results comparable. Yeah.
And just as a side point, I guess if people are interested in evaluation measures, we're very happy to share the ones we're using. We're about to revamp our evaluation program because, of course, the diagnostic criteria has shifted with ICD-11, plus the introduction of complex PTSD. So we'll be capturing that as an endpoint as well in our client population. So if anyone is curious, it's not a state secret. We're very happy to share that information. We've done a lot of consultation around which instruments we're going to use going forward from January next year. So I can't see any more questions. Agarit, that's fabulous. You have just done such an amazing job wrangling all these data into something that we can actually interpret. So thank you so much.
My pleasure. Thank you for having me. Bye.
Bye-bye. Okay, so we're a little bit ahead of time for the first time today. Hopefully our next presenters are standing by and they're ready to, yes, I'm getting the nod. Oh, there they are. Hello. So it's my great pleasure to introduce our final presenters. It's actually a panel of presenters, actually. So you'll get lots of variety in terms of people's style, and I'm sure they've coordinated themselves very well. So they're going to be word perfect in their own areas. I just wanted to introduce Professor Renata Kukanovic and Dr. Emma Louise Seal and Dr. Tamara Borokova. Oh, sorry, Borovica. Very sorry, it's getting a bit late in the day. All from RMIT, and we work with this team as part of an ARC linkage grant led by Renata, and it's been a very exciting few years. So Renata herself is leading the Social and Global Studies Centre at RMIT, and their specific focus at the moment is lived experience of mental health. And so they've done a very interesting and exciting conference, or I guess it was really a huge kind of what would you say? It was like a big display. Yeah, the festival. Thank you. The Big Anxiety, which is recently. So some of you may have heard of it. Hopefully some of you actually attended some of the events, because that was a very big and exciting activity, and certainly lots of lived experience involvement there. So the ARC linkage project is called Borderline Personality as Social Phenomenon. And they're collaborating with Spectrum and many other organisations as well, which I'm sure they'll tell you about. And Renata has expertise in interdisciplinary cross-sectional mental health research, and her aim is to develop creative mental health supports that can be accessed by the community. Emma Louise, her research explores the presence and impact of health, especially inequalities, and she applies these in her mental health research. Mental health research. And Tamara, well, I'm nearly there. Her research focuses on the embodiment and psychosocial approaches to mental health. And I'm going to just say thank you and welcome and take it away.
Thank you, Gillian. We will just share our screen. So hello, everybody, and thank you, Gillian, for such a wonderful introduction and giving a brief overview of our project and also our research team. In this brief presentation by our research team, I will cover research overview and aims of our project and tell you briefly about our methodological approach and our methods. And after that, I will hand over to Tamara and Emma to situate our research in an existing literature and also to present some of the initial findings from our research. And we are hoping that in the next year, probably we'll have more time and more opportunities to share more insights as we go and as we develop the project. As Gillian mentioned, our core research team is Tamara and Emma and myself, but then we have a number of research partners which are listed here. So as Gillian mentioned, this is a large interdisciplinary team covering social sciences, humanities, creative arts, psychiatry, psychology. We have a number of partners in Melbourne, but also international partners at Goldsmiths University and University of Glasgow. Our partners include Spectrum, and Satya and Gillian are one of our key collaborators. So our project is also governed by the Lived Experience Advisory Group, and we also have advisory group of other kinds of experts who are contributing their knowledge to the development of the project. As this is Australian Research Council linkage project, we developed the project with the key national mental health stakeholders, including Spectrum, National Mental Health Commission, Lived Experience, Australia, and others, as you could see on this slide. Our research overview includes a couple of points about our focus of the research. So we are aiming to collect personal narratives of people either self-diagnosed or being diagnosed with BPD and to explore their lived experience. We are also interviewing health and social care practitioners to see their to explore the way the way they provide care and support to people with BPD. Our interdisciplinary research really focusing on self-generated and creative accounts of BPD in the context of everyday life. So we are exploring those diverse experiences and try to situate it in the complexity of people's everyday life. And our key focus is really exploring the lived experience. So we have a number of research aims, as you could see on this slide, but one of the key aims is to improve social support for people who are diagnosed with BPD, but also to raise empathy in the community. And this is what we were also trying to do with this big mental health festival that Gillian was mentioning, working together with people with lived experience to present their experiences in the way that are conducive to them and to raise awareness and empathy in the community. We are also hoping to advocate for lived experience to be included in the policy, practice and service provision as a key expertise. And we are also going to facilitate workshops with stakeholders for knowledge synthesis and translation, but also dissemination. Moving on to our methodological approach, As mentioned, we are using a number of qualitative methods. We are using narrative interviews, arts-based workshops, and we also conducted a national qualitative survey. National qualitative survey was the first phase of our research, where we collected about 150 accounts of people with experiences of BPD, who were provided in different forms, including written narratives, including some creative arts outputs like photographs or paintings or poems. This was followed up by creative arts workshops. We had 6 of those workshops. Our collaborators from Monash, who are experts in creative arts methods, in collaboration with Tamara, were running those workshops. And then again, they were a couple of hours long events where people were invited to contribute their lived experience and expertise through various creative forms. And the other key aspects of our research methods in narrative interviews. We are collecting interviews, exploring people's accounts of their of living with BPD. Interviews are usually quite long because we do allow people to talk as long as they want to share with us aspects of their experiences that they are interested in sharing, and also thinking in experiences that they think could be useful for others to learn from. Using those range of methods, we really try to foster inclusion of diverse ways of knowing, which means that we are not privileging a particular kind of knowledge, such as expert knowledge, but also lived experience. And we are also looking into creative ways to synthesize this knowledge through and implement through knowledge translation. And the last slide, I think, that I'm talking about, just to summarize our methods with lived experience interviews. We were focusing on capturing people's experiences of living with BPD diagnosis. Arts creative workshops also were contributing to alternative ways of knowledge that we could which we could try to understand people's experiences, and also narrative interviews in particular, but all the other methods are also contributing to development of the online resource that we are currently working on. And this resource would be launched probably May next year as a part of Health Talk Australia, that we are working on, which is depository of lived experiences of various mental health and other conditions. So this resource that we are developing will be aimed primarily for people with similar experiences to learn from others and to learn from their experiences, but also for health practitioners to consider broader incorporation of lived experience, expertise, and knowledge into various treatment options, and also, as mentioned, to increase empathy and knowledge in the community about this particular condition. And so I will then hand over to Tamara, who will say a few words about situating our project in the existing literature. Over to you, Tamara.
Thank you, Renata. Okay. So I'm going to talk to you today a little bit about the key points from the existing literature we are exploring for our borderline personality social phenomena project. So I will start by saying a few facts that I'm sure are probably well known to at least large part of the audience today, but we do need to situate this research into the existing field. So personality disorders, including borderline personality disorder, are considered to be among most societally misunderstood, contested, and stigmatized psychiatric categories, according to Nick Manning, a site of psychiatric controversy. This is obviously particularly challenging for those diagnosed with PDs and their families. In Australia, the number of individuals living with borderline personality disorder is assumed to be somewhere between 250,000 and 1 million, with the prevalence ranging between 1 and 3.5% of the population. which is slightly less than the international statistics, but still quite high, with females significantly outnumbering males in most settings. International studies also indicate considerable variance in the prevalence of BPD across different geographical regions and populations. This stark discrepancy in numbers has most recently been coupled with the growing recognition that experiences and behaviors diagnosed as BPD are rooted in social and cultural phenomena, particularly gender, social disadvantage, marginalization, and complex trauma, which is not making this picture any easier to understand. The literature is suggesting that most common problems with defining personality disorders, such as BPD, are an overlap between personality disorders and trauma responses, and diagnostic overlap between BPD and other psychiatric diagnoses, and historical and contextual trends in defining what fits and what differs from cultural standards. In medical humanities, PDs in general, and particularly BPD, have been theoretically and clinically linked with attachment trauma and or complex trauma, with complex trauma seen as one of the causes of individuals' problems with self and identity. The literature further suggests that individuals diagnosed with BPD are over 13 times more likely to report childhood adversity than non-clinical controls, and more likely to report emotional abuse and neglect. Furthermore, for many, this childhood adversity includes childhood abuse and early sexual abuse. The literature in medical humanities is largely suggesting that a high number of instances of BPD could be understood as complex PTSD. It is worth noting that the critiques of BPD as a controversial diagnostic category and these calls for a different approach to understanding personality disorders, one that is more grounded in sociocultural aspects of one's life, still do not necessarily help those who lived with this condition and their families. So in qualitative social sciences, BPD is conceptualized and understood from a more critical and often inclusive of lived experience point of view. For example, Sarah Radikoff utilizes feminist critical disability studies to explore BPD as a site of knowledge production, particularly about emotionality and ways of learning through emotionality. For Radikoff, careful reconsideration of BPD points to the limits of Western epistemology that only reluctantly grasps with the nonlinear nature of emotionality, visceral knowing, and traumatic memories. Further on, Weinerk, which on the slide is point 1 for you, suggests that BPD to be considered as a relational or liminal disorder due to the focus of distress usually being in the liminal space between individuals. For Mary Lisa Johnson, BPD is important as a site of intense emotional and embodied pain. Johnson notes that pain is an umbrella for felt sensations of BPD and therefore needs further exploring and contextualizing. Johnson also notes that BPD is gendered and often racially narrow representation that tends to erase diverse populations while mainly pathologizing women. To this end, the contested nature of BPD, the stigma and gendering of the diagnosis, and research pointing to experience of BPD having strong roots in childhood trauma make it a shifting phenomenon that requires interrogation grounded in the narratives of those with lived experience. And moving on to the discussion of the lived experience explored through this research, I will now introduce the overall emerging insights from the lived experience narrative interviews before I hand it over to Emma to talk to you about more concrete insights. As Renata mentioned earlier in this presentation, narrative interviews are the final stage of data collection that builds on the previously collected data via national online survey and arts-based workshops. We are conducting narrative interviews with lived experience population and with health professionals, but for the purposes of this presentation, we will be focusing on lived experience perspective. The slide that you're seeing now gives an overview of 12 emerging themes coming out of these interviews. These themes have been identified in an iterative process, including core research team, our lived experience advisory group, our project investigators and partner investigators, and our wider advisory group. And as you can see, the themes that we are currently working with encompass a broader view of individuals' lives, ranging from personal relationships, everyday life, experiences of trauma and stigma, supports available through mental health system and wider community, well-being supports, experiences with medication, as well as managing lived experience within peer workforce. And I will now pass it on to my colleague Emma to talk to you in more detail about a few of these themes.
Thanks, Tamara. You haven't seen my face yet. Hello, everyone. So as Tamara mentioned, I'm just going to touch on a couple of the key insights that we just wanted to share in the context of our presentation today. So the first one is the idea of everyday life. And the concept of everyday life emerged from participant interviews when they were discussing different aspects of managing their day-to-day lives and the daily expectations and activities they were engaged with, or indeed wanted to be engaged with. So we really feel it's important to bring to the surface the everyday work and labour that people discussed in these contexts to manage different aspects of their emotionality in order to feel a sense of stability, but also in order to project one to others as well. So it was apparent that participants reflected on this in the context of their BPD diagnosis. So, for example, the need to come across as being stable and well and coping and managing became important to sort of avoid being reduced to common stereotypes and basically common stigma and discrimination that we see in the context of the BPD label. And this was primarily related to people and situations in which the diagnosis was known. So I've got a few different aspects that we're just going to touch on here. So in relation to managing families and relationships, it was quite apparent that stable and predictable relationships are important in this context, but these are not always present or easy to find. So a lack of education and support for family members can also create issues and sort of generate additional struggles for all, which require sort of constant navigation. For those participants with children, there was discussion around the sense of needing again to sort of keep oneself stable whilst managing childcare and sort of childcare expectations, and how to negotiate their diagnosis with relevant sort of school and childcare contacts. In relation to sort of managing work, which was obviously a factor in many of our participants' lives, when describing their work lives, they talked about the challenges associated with managing roles, with managing relationships in their emotionality in workplace settings. So again, a preference for stable environments, but obviously an ongoing challenge to find these stable environments. And financial hardship as a sort of consequence of this was raised by some as an issue due to the challenges associated with sort of maintaining ongoing stable employment. Working from home in the context of COVID did alleviate this for some people as well. And the final point in relation to managing education and study. So what came up here was sort of participant struggles around managing and holding down sort of education and study cycles, sort of cycles of coming in and back out of education, but wanting to sort of feel like they could sort of maintain that, and juggling education in relation to sort of taking medication. And there's obviously lots of different ways that managing that came out in relation to having a diagnosis of BPD, but these were sort of the ones that sort of were quite prominent in many of the participants' accounts. And the final sort of insight or theme that we've got time to discuss today was some of our accounts of participants that came from those that have experience either currently or previously working in the peer workforce or in different healthcare settings as peer workers. So a theme that was maybe surprising for us but emerged quite strongly was how participants negotiated and managed a BPD diagnosis in these settings. So there was sort of quite consistent discussion about being fearful to discuss or disclose a BPD diagnosis because they felt they would be reduced to this label in that context and not necessarily taken seriously in their position. So there was a lot of avoidance. And obviously no one is at liberty to disclose a BPD diagnosis, but it was just in the context of people explaining that they would never feel probably comfortable exposing or sort of saying that they had a diagnosis in that context. So that sort of emerged from participants describing a variety of different experiences where they had their own observations of poor practice when healthcare providers were working with those with a diagnosis of BPD, and how often they observe people's approach shifting depending on what a person's diagnosis might have been. So they were observing how other people were being treated, and that sort of affected them. So this sort of generated everyday tensions and distress for some as they negotiated, knowing that they had this BPD diagnosis, but also observing how others were being treated in the settings that they were working in. So this really culminated in the sense of feeling powerless because they were unable to maybe change or negotiate or challenge these power hierarchies, and were sort of left with ongoing feelings of distress and discomfort. And we think this is a really important sort of finding in the context of, for instance, the Royal Commission and findings and recommendations that are emerging in the peer workforce and lived experience space. In terms of building this going forward, I think it's really important to sort of understand some of these issues. And that's sort of it from me. We've got to round up, obviously, again, just our partners that we'd like to thank, and obviously all of our participants and advisory group people that have been involved as well. References, and also obviously just thank you, and any questions, and we're going to come back together for questions so that it's not just me in the firing line. So thank you for listening.
All right, I encourage everybody to pop in a question or a comment into the chat, please, and I can relay that to our wonderful presenters. Thank you so very much, three of you. That was a really well orchestrated presentation, very smooth transitions, and it's fantastic. One of the things that I'd like to just comment on is the nature, the focus of this study. It's not a clinical study like we so often do. It's actually getting at that question of diagnostic complexity by going to the people with those experiences and asking them to help teach us, I guess, as well. And I think that's it's a real strength. I think we can hypothesize and we can theorize all we like, but really unless you actually get down and you ask the questions, we're not going to really understand. And I just wonder if your experience, you know, just listening to Tamara talking about the literature as well, it's presenting in context with what the lived experience participants have been telling you. How is it changing the way that you felt about it compared to how you started out with this project? And I don't mind who answers, anyone who'd like to.
We might, give collaborative answers. Thank you, Gillian. Well, some things are changing, some things it feels like we're just getting affirmation from consulting with the lived experience population that, for example, one of the key things that emerges in the literature is this discussion of the link between borderline personality disorder and other traumatic events in people's lives, whether it's like childhood related trauma or some kind of childhood adversity or later on events of trauma. I don't think we actually expected that we will hear as many accounts of complexities that people are navigating due to these events that we have heard. So in that way, we are getting more deeper insight into what literature has already identified. But I think a point that is emerging, that is changing our approach to the literature, is like really understanding the complexity of everyday life of someone diagnosed with BPD and their families. Like what Emma was presenting a moment ago is the degree of everyday work and everyday thinking that goes into managing lives that, some others wouldn't really considered as an obstacle to someone else. So the everyday, the intensity of everyday labor is definitely something that we will be contributing with this research.
Thank you.
Maybe just add to it quickly. I mean, those debates around the diagnosis of BPD are very well known, I'm sure, to the audience that we are talking about. But it's really amazing in our sample, because it's qualitative study, so we are not talking about large numbers, but the diverse ways of how people narrate about their experiences of being diagnosed, what diagnosis means to them, whether they internalize it or not, whether they unpack it in some other ways. Also talking about the ways how diagnosis is given and in which context, and then what kind of support they get to actually understand what's going on with them or in their lives, regardless of how they received or perceived that particular diagnosis. It's very, very challenging for people to negotiate those kind of terrains.
One of the things I noticed, I think it was in your part of the presentation, Emma, was the potential interference of medication with study and perhaps with employment as well. I'm just noting Ian's presentation earlier and the fact that pharmacotherapy is often a first-line treatment for people with borderline personality disorder, even though that's not actually an evidence-based treatment approach. I'm not going to say you should never give medication because given the co-occurring disorders, perhaps they're used to treat other disorders, but I'm just curious, what was the context and how frequently was medication a barrier to engaging in education and perhaps employment as well in your study?
It's really difficult to sort of quantify exactly,
Yes.
how many people have said what, but I think it was just sort of emerging that, like, although people felt that in certain situations and scenarios medication had a place and it had efficacy for them, depending on how it was given, how many medications were given, what the follow-up was, it could then, that trail off effect sort of then did sort of start impacting people in a variety of ways. For instance, people like wanting to engage in study but maybe struggling to concentrate and feeling like they couldn't concentrate in that setting because of the medications, or for instance wanting to get back to some exercise but feeling like they'd put on a fair amount of weight and then not feeling comfortable to exercise. And so it has all these little offshoot consequences that sort of trickle down into people's daily living, and although it does have a place in certain scenarios, it was more what was the ongoing sort of prescription of that medication like, and did they have a discussion about what that medication could do and what were their alternatives. And so there was sort of different, I guess, touch points where you could see that actually, people's lives could be improved if it was delivered and sort of managed, I guess, in a different way. If that makes sense. And
Yeah, thanks very much, Emma. It's a difficult one, that one. And I also, something I did want to comment on as well was the opportunity to express people's experience of BPD through art. Now, you haven't actually presented specifically on that, but I'm sure there's people out there who are quite curious about what that might look like and perhaps what it might tell us as well.
Tamara, would you like to?
Yeah, can I?
Is our creative arts expert in the team?
Representative. Yeah, well, only briefly that we are putting all the data together at this stage. And I think this presentation is more to give an overview of the project as a whole, and then some snippets of the types of insights we are developing for now. But next year we will be able to present much more in depth on the varied data sets and what comes out of the different data sets. But we're looking at the creative inputs we have received so far. They definitely bring, I would say they tend to open new questions in terms of how the emotionality of living with something that is diagnosed with BPD can feel to someone, and what are the consequences that feeling then can have on their lives. So we're getting lots of very abstract but illustrative inputs through poetry, through visual images, through music making and similar. And our arts making workshops were another aspect where partly due to a group focus of art making in a group context, where a group of people were coming together over a period of time and using different arts-based methods to elicit different responses to what it means to live with the diagnosis of BPD and how this condition is affecting people's lives. We got a little bit different presentation in terms of more focused on the positive sides of living with a complex mental health conditions such as BPD, and looking for things that are encouraging or compassion building or empathy building. And yeah, we look forward to presenting more about all of that next year.
Yeah, thank you. And apologies for throwing you in the deep end on that one.
No, that's okay, because we are working through. I just would like to add, because of the complex data sets that we have, multiple qualitative methods that we use. We are now, the next phase is really, as Tamara mentioned, making sense of all of this into one kind of integrated picture, because I just want to mention that each method of data collection actually yields slightly different, not different results, but provided a different focus on the kind of people's experiences. In a group context, as Tamara mentioned, it was more like a positive and hopeful. In surveys, which are anonymous surveys that people were doing in their own time, in their own space, accounts were much more bleak, I would say. And interviews are mixture of different kind of accounts. So it would be a challenge, but it's a challenge that we are looking forward to work on with our collaborators, including yourself and other people that we work with. So we believe that we would really have a very interesting picture of living with BPD based on all these data sets.
Yep. Thank you. And if anyone's listening out there with a question, this is your last chance. Please pop it in the chat. I just have one closing comment / question, and that's, I'm really interested that one of the themes you explored is the theme of the peer workers who have lived experience themselves working in the mental health system in some capacity. And I think with the growing focus on having lived experience involvement in all levels of the mental health system, particularly here in Victoria, I think that's a really pertinent focus, because it does present unique challenges both to services and to the individuals who come to work in that peer worker capacity. So I just wonder if you had any closing thoughts in terms of what you've found through the study so far.
I think that because obviously we weren't intending to focus on peer workers, it just sort of emerged because of the group that sort of, but I think that what it's showing is there probably is a need for more research in that space to really sort of explore and interrogate some of these issues further, and just do that work, I guess, in a more considered way, when we're going in and sort of asking these questions specifically. So I think that it's sort of raising opportunities. I can see Renata's shuffling.
I just want to add what I would like to add is what coming from Emma and Tamara's analysis of that particular question. Is really, even though we are working with small samples, but the nature of BPD as a particular diagnosis being stigmatized, even in the mental health and NGO sector who supports people with lived experience. So people do not have an issue stating that they have lived experience of mental health concerns, but they do have a specific issue about saying that it's about disclosing that it is BPD. So just to clarify, it's not like depression or any other diagnosis, but BPD, because they, based on their accounts, they see how BPD is discussed in a particular work context, and this is what they do not want to disclose because they are concerned how they would be then perceived by their colleagues.
Thank you.
Environments.
Yeah, thanks, Renata. Yes, I think I had a little bit of a misunderstanding about that theme. So that's not so much the peer workforce as in people with lived experience who are in the workforce, in the mental health workforce.
No.
Yep. Oh, that's fantastic. Thank you so much. This is a really exciting project. It has so many moving parts. You've been working really hard. You've had all the limitations around lockdowns around Melbourne too, in terms of the way you've run workshops and done your interviews and all the different people and organisations you're collaborating with. So it's amazing work. You're a great team, and it's a real pleasure to work with you all. So thank you.
Thank you, Gillian. Thank you, Gillian, for your ongoing support, and thank you all.
Okay. So this brings us to the close of our research forum, our second research forum, and I hope that you've all enjoyed it and found something exciting and interesting and expanded your thinking about personality disorder and how you work in the field if you do, or how you might like to do something in the field. I'd like to give a big thank you to all of our presenters and to the Spectrum staff as well for making this happen today. We have a fabulous workforce development team behind this, making it all run very smoothly, and a special call out to Olivia Smith, who's going to be very embarrassed if I look around at her, but she is probably the person that all the presenters had most contact with, and she has done an amazing job of editing and reminding, collecting information. All the presentations, the slides, the bios, and the recordings of today will be available to you all. So if you had to step in and out for other daily activities today and you'd like to come back and relive or experience the presentations that you missed, you will be able to do so. So I just want to ask you all to complete the brief little survey that's going to be sent around, just to let us know what you really liked, what we could do a bit differently. We got some great feedback from last year, which really helped shape the presentation of the format of the forum this year. So, and thank you all for your attention. Thank you for attendance and your interest, and we look forward to welcoming you at our forum next year. Goodbye.